We acknowledge the traditional owners of the land on which this podcast was recorded, the Wurundjeri Woiwurrung and Boonwurrung peoples of the Kulin Nation, and pay our respects to their elders, past, present, and future. Welcome to the podcast series of Raising the Bar Melbourne, curated by the Faculty of Medicine, Dentistry and Health Sciences at the University of Melbourne. This special health edition of Raising the Bar, held in May of 2026, featured 20 talks by some of Melbourne's leading healthcare experts and was held across 10 pubs and bars, all in one night. The speakers presented topics ranging from AI and cancer research to understanding ADHD and neurodiversity, helping kids sleep, healthy social media habits, the future of robotic surgery, and much more. In this episode, you'll hear Professor Lauren Ayton co-present with her patient Cameron to talk about low vision, vision loss, and emerging clinical trials and technologies of the future. Before we jump in, we'd like to apologise that due to technical difficulties, the first few minutes of this talk was not recorded. We note that Lauren Ayton's introduction is not included, and the talk will start halfway through Cameron introducing himself.
I live with vision loss. I'm not blind during the day, but here at night, looking out, I can see a couple sort of heads out there, but that's really about it with the light shining in my face. But, you know, during the day, I'm able to function somewhat normally at the moment. So, that's a little bit about me.
Amazing. And so as you can probably tell, we're going to kind of tag team a little bit. I'm going to talk to you a little bit about the science and then ask Cam to sort of comment on what this means in real life. So I'm going to take you right back to the start and talk about vision as a sense. So most of you will be surprised to know that actually over half of our brain is dedicated to vision, either to actually interpreting the visual signals or making sense of it. So connecting in what we see with what we touch, what we hear, and what we feel. But if people lose vision, other parts of their brain will obviously step up the game a bit, but it takes more effort. And so this is one of the key things that people often don't understand about low vision is, you know, the effort I think it takes to do that. And so, Cam, I guess I'd like to throw back to you on that. What do people not really understand about what it is like to live with low vision?
So for me, I've had the lower vision has come on slowly, so I've been able to adjust. But one of the difficult things is not being able to trust your vision. So, lately, I might see something if I'm going for a run at home. 9 out of 10 times, I might see that street pole. But there's been times where I haven't seen it, and then I've ran into it and whacked myself. So not trusting my vision is scary, and sometimes I'm at the stage now where I'll put my arm up, even though I'm sure there's nothing there. I'll still make sure. So I guess there's that, and then other times, as Lauren said, my brain. If I see something, if I can half see, my brain will fill in the blanks, and sometimes it fills in the blanks and it's completely wrong, and I'll see something and it's just not at all what I was looking at, but I'm sure it was.
And I think that's a really perfect example of how complicated vision is. So I'm going to take you right back to the basics. So when we see something, what we're actually seeing is light reflected off an object. And so the light that's reflected back comes in through our eyes, and actually when you think about it, it's quite amazing that it works at all, because the light has to go through your eye. So it has to go through the cornea at the front of the eye, which is the clear part. It's got to go all the way through the different tissues, and then the retina that Cam mentioned is actually right at the back of the eye. But the crazy thing is that the cells that respond to light are right at the back of the retina. So the light has to go all the way through the eye, all the way through the cells. Then it is reactive and it turns into electrical energy. And then that message has to go all the way back through the retina before it can go to your brain. And so you can imagine along that pathway, there's so many things that can go wrong, right? And so it is quite interesting to us as vision scientists how the different parts of that visual pathway fit in together. I am a retinal specialist, so that's my area of interest, and in particular genetic and inherited eye diseases. And so I'm very passionate about the retina. It's an amazing tissue. So it's almost like the film in the camera, but it's an incredibly power-hungry film. So the retina in our eye actually uses more oxygen than our brains do, but the retina itself is incredibly fragile. So it's about the thickness and the fragility of a wet tissue. And so as you can imagine, again, it's actually quite easy to tear that retina or for damage to happen to the retina, which again can affect your vision. The other really cool fact about the retina is it's unique. So it's actually completely different in every single person. And that's actually quite interesting for us because it could potentially be used like a fingerprint in the future. I think many of you might have seen Tom Cruise in Mission Impossible where he has the retinal scanners. That's true. So, it is a completely unique signal to each person. The other really cool part about the retina and the eye is it actually starts forming in an embryo at about 6 weeks. So the eyes actually start forming before a lot of other organs in your body. So the complicated nature of the eye is really, I guess, reflected in the evolution of how it works. When the light gets back to the retina, Cam mentioned before that there's 2 types of cells in the retina that respond to that light. So there's rod photoreceptors and cone photoreceptors. This is one part of medicine where we haven't been very imaginative. So the rod ones look like rods, the cones look like cones. So it's nice. There's no big fancy name for them. But what they're really special at doing is actually differentiating our types of vision. So now that you're sitting in this really dark room at the moment, what's actually working are your rod photoreceptors. So they're more sensitive to nighttime vision and dim lighting. And they're also more sensitive to motion. And one of the really cool evolutionary facts with human eyes is that most of our rods are at the peripheral part of our sight and our retina, and most of the cones are in the central part. So it means that our high vision, our high acuity vision is in the centre. We're better at seeing colours in the centre, but we're much better at seeing in the dark towards the edge, and we're much better at seeing motion towards the edge. And that's an evolutionary trait, so that if a bear is chasing us away, then we can see it from the edge as well. So out of interest, has anyone in the room ever fought with someone about what colour something is and that you're convinced that you're right? Excellent. I love doing this. If you are a woman, you're probably right. So women... Just in general, it's a total fact. So women tend to have better colour vision than men, and that's both in terms of the fact that men are more likely to have colour vision problems, and so there's differences in the photoreceptors in about 1 in 12 men will have those issues. But even generally, most women actually have better colour vision in our cone photoreceptors. If any of you have ever been interested in what it's like to have a colour vision problem, the best way I can describe the most common of those conditions is the red-green colour blindness. And if you think about a tomato and when it's completely unripe, all the way through to being beautifully ripe and red, for someone with a red-green colour deficiency, that looks the same to them the whole way along. So not great for judging tomato ripeness, and also not great for other parts of life as well. So the really interesting thing, which Cam just alluded to as well, is we have these anatomical features in our eyes that help us see in different sorts of situations, but it's actually not really our eyes that see, it's the brain. So the signals that come from your eye back to your brain are then interpreted by the brain, and our brain is really, really good at working out what it should pay attention to and what it shouldn't. And a good trick to do this, and a few of you might have had a few drinks, which will make this even more fun, if you really quickly flick your eyes left to right, so just looking around the room as crazily as you can, what you'll realise is the room still stays still. So even though you're moving your eyes in a really rapid nature, your brain knows that the room isn't moving that quickly. And so this is a really important part of vision, and this is something that can be affected when there's brain injuries, for example, and we have a discrepancy between the eye and the brain. And as you can imagine, that can be very debilitating for people if their whole world starts moving. Another really fun trick with the eye and the brain is the fact that everyone here in this room actually has a blind spot. So we all have a spot in our vision where we can't see, and that's the spot where the nerves from the eye actually go back to the brain. So there's a part in your retina where there are no photoreceptor cells, so we have no vision. And you can find that yourself. So if you want to put both of your hands out at arm's length, great. Oh, I love doing this and everyone doing it. I want you to close your left eye for me. And then I want you to move your right finger outwards. So starting it so they're together and then moving it out, but keep watching your left finger the whole time. And at one point, as you move your finger out, you'll realise you can't see your fingernail anymore. Sometimes you have to do it a few times to sort of work out where that is. But the point where you can no longer see the top of your finger, that corresponds to your blind spot. But we never see this in day-to-day because our brain maps it in for us. So our brain knows that shouldn't be there. But unfortunately, when you've got lots of blind spots around the retina, then it can be trickier for the brain to fill in those spots as well. So that's a really big take-home message from me, I think, is we think a lot about low vision, being big black spots, for example. And out of interest, in the audience, if I said the word blind, how many people immediately think of blackness and not being able to see anything? So it is a very normal sort of reasoning. So people often think of blind as being what we call no light perception. That's actually incredibly rare. So most people that have low vision will still have some different types of vision. And a really big part of our research and the different clinical people that work with people with low vision is trying to work out how to use that most effectively as well. So Cam, I want to throw back to you at this point. So I've talked a little bit about the science and, how the brain maps in these gaps in our vision and things. I was wondering if you can tell us how your vision has changed over time. Has it been always the same as it is, or has there been variations over time?
Yep. Well, firstly, I'll just mention that this is my experience, and I think it's really important to know that everyone with low vision or blind, it's completely different for everyone. So for me, as I mentioned, I was diagnosed at about 10 years old. I had some childhood eye conditions like astigmatism and long-sighted, that sort of thing. And I remember bugging Mum to say, to tell them about my night. I can't see at night. And, I was at soccer training and couldn't see. And that was sort of I don't have any memories of being able to see at night. I've never been able to. And so diagnosed, went through that process, and then they went in for a routine checkup and come out saying, your son's going to be blind by the time he's 20. So that was sort of confronting. And then through my teenage years, it became apparent that probably wasn't going to happen at that rate. But the night vision was always really difficult. So growing up in different social situations and even to this day in a place like this, I love going out with my friends, but, there's many awkward moments when you meet someone and like you can't see them and they're shaking your hand, you can't see their hands out, but, 5 minutes later or even up here on the stage, I would be able to see your hand and to be able to shake your hand and see you, but down over there, I wouldn't be able to see it all. So there's some of the challenges in terms of changing over time. Again, like through my 20s and stuff like that, I've keen mountain bike rider and like skiing and doing all those sorts of things. Now I'm in my mid-30s and that's harder to do. I can still do them, but I have to go slow. I have to be really careful. The hardest thing for me recently, not that recently now, probably about 4 years ago, I couldn't drive anymore, and then that adds a whole nother element in, losing your independence in driving. So that's another change. And but it is sort of very slow, sort of, and you don't notice it day to day. Sometimes you sort of just be outside and you think, geez, crap, I swear I could see that the other day. And, you think, oh, no, I'm just tired, or the sun's bright or something, and you put it down to that. But realistically, there's little things happen here and there. I also notice at night, in the evening, after a long day when I'm tired, it's worse than than in the morning as well.
Yeah, absolutely. And so Cam mentioned that he has a condition called retinitis pigmentosa. It basically means it's a condition of the retina. It's actually misnamed. I don't know if you know this, Cam.
30 years I've had this and I still can't pronounce it correctly.
That's right.
I just say RP.
Many of us can't either, so it's okay. So the retinitis, if you guys know anything about medical terms, itis on the end of a word normally means inflammation. So originally they thought it was an inflammation of the back of the eye. It's actually not. It's a genetic condition, and so it's nothing to do with inflammation. The pigmentosa part is because there's pigment changes, so there's sort of black spots in the retina that we can see when we look in, and that's where it gets its name. It is a genetic condition that I mentioned before, and these genetic conditions, historically there wasn't sort of many options for treatment. And this is quite different to a lot of causes of low vision. So things like cataracts, we can do cataract surgery very easily. So cataracts are an opacity in the lens in your eye. Again, like a lens in a camera, it just goes a bit white as you get older. Very, very easy. They do a surgery, take it out. Literally takes 8 minutes. It's quite amazing. So that type of low vision has had a treatment option for quite a long time. We've got really good treatments now for things like glaucoma and macular degeneration and some of the other eye diseases you might have heard about. But for these genetic eye diseases, when I went through my clinical training, there were no options at all. What's incredibly exciting now is that we are starting to learn more and more about the condition. So we now know what genes cause RP. And to give you an idea, the first gene that causes RP was identified in 1984, and we now have over 450 known genes. So it's a huge trajectory in the field. We're learning more and more about these genes every week at the moment, to be honest, which is slightly hard to keep up with. But that gives us so much hope now because we've got ways of using personalised medicine to actually try and correct vision. And so I'm going to talk you through some of the techniques that we're using for these inherited retinal diseases at the moment. And again, 5 years ago, this would have been a completely theoretical talk. Now, all of these are in clinical trials, and most of them are in Australia as well. So it's a really exciting time to be part of this research. So the first is a technique called gene therapy. And so with these inherited retinal diseases, they're very interesting because they're caused by a mutation in one gene. So to take you way back to the basics of biology, genes are basically the information that our cells need to make proteins so our bodies can function. And within those genes, those instructions, it's very, very easy for some of it to get mixed up. And so in these conditions, it's just one gene that is the problem. So what we can do is actually get a correct version of that gene and we put it into a virus because we know viruses are really, really good at spreading, hence why we all get colds regularly. But these viruses are very special because we scoop out all of the bits that make people sick and it's just a carrier. So basically we can then put in a correct version of the gene. It gets injected into the eye. And the really, really exciting thing with the eye is because it's an enclosed space and because the retina doesn't actually change after you're born, apart from possibly deteriorating, because it's not growing, it means we can treat that eye once and it should stop vision loss entirely. So that's the idea with gene therapy. We want to have a one and done injection where we can actually see if that will halt disease progression. And there is now one gene therapy that's been approved for use. So we got a TGA clearance for that in 2020 in Australia. And on that, on the market approved drug, we've had about 30 people in Australia that have had that. And there's many more coming through, which we'll talk about in a second as well. So this is a really exciting area for us. But there's some of the conditions where gene therapy won't work. And usually it's because that error in the gene is too big. So if it's too big, it won't fit into a virus. So then we have options of, okay, well, do we split it into multiple viruses? But then how do we know it's going to join up when it gets into the eye? Maybe we can put it in something else. And so there's some really clever people working on ways of coating these genes in gold or in lipids, so fats. So all sorts of interesting ways of getting the gene into the eye. Or what we can do is go, right, rather than trying to add something to the eye, maybe let's edit what's already in the eye. And so this is called gene editing. And so in this sort of technique, what we do instead is almost, like they call them molecular scissors. So we're using an enzyme in the eye to get rid of the faulty part of the gene and then pop in a correct version of the gene. It honestly still feels like science fiction to me that we can do this, but we're able to do that. And this is a technique which is really good for genes which are too big. Of course, that doesn't work for everyone as well. So some of the other avenues that are being developed are drugs, so small molecule drugs which can help the cells in the eye respond differently. And there's also a technique called optogenetics. I promised not too much jargon, but bear with me on this one. This is a very, very cool technique. So there's an algae which grows in ponds, and what the algae does is it actually absorbs light and it produces electricity. And so scientists went, oh, if we can do that, what if we took that component from the algae, put it into the eye? And so what we can do is put that into cells that never used to be responsive to light, and we can make them react to light. And so we can basically jig it so that we've got these new fake photoreceptors that then start responding to light. So that, again, is in clinical trials around the world, including in Australia in a few months. We're going to start our first trial there. The last one I want to talk about before I throw back to Cam is the bionic eye. And so Bruce mentioned that at the start. And this is actually an option for people where the disease is more progressed. So the bionic eye we talk about being for people that don't have any form vision anymore, so they might just have bare light perception. So to give you an idea, if you close your eyes now, that's kind of the baseline level of vision that people that get these devices have. So you might be able to make out the spotlights on the roof, but you definitely won't be able to see anything else in the room. What the bionic eyes do is they allow people to see little spots of light. So there's a camera on a pair of glasses that takes a picture of what they're looking at. That's then sent to electrodes, which are implanted in the eye, and it allows them just to see spots. So as you can imagine, that takes a lot of training to get used to because it's not a normal picture. What you're doing is going, okay, there's a lot of spots over there. I think there might be a doorway there, or maybe there's a lot of spots here on my table, so that's where I know my notepad is. So really complicated rehabilitation, but has been quite exciting for people at that more progressed stage. It's actually had a bit of a revival recently, thanks to Elon Musk. I don't know if I say that very often, but you might be aware that Elon Musk has a company called Neuralink, looking at brain-machine interfaces, and one of his team members, who was the president of that organisation, now has a new company to make bionic eyes. And so, again, we have bionic eyes in trials all around the world, including in Australia. So incredibly exciting. And so, again, as I mentioned, this is literally all within the last 10 years that we've actually had these options come through. And the only way that we can actually test whether these treatment options work is obviously to run clinical trials. Now, clinical trials are always challenging for people that are involved in them, but it is extra challenging in these sorts of vision trials because we can't just do something as simple as ask someone to read some letters on a chart. That's not specific and sensitive enough for what we're looking for. So what it means is we actually get people to come in after they've had a treatment and we get them to do some vision testing, we take photos of the eye, but we also get them to do things like walk through obstacle courses and look for objects on tables and all sorts of quite time-consuming tests. And so Cam is actually involved in one of our clinical trials. And so I really wanted to give you the opportunity to talk a little bit about, what made you want to do a trial, and then how have you found the experience?
Yeah.
And obviously say how great we are.
Yeah. All seriousness, we were chatting before and you were saying, oh, thank you for being part of the trial. For me, I'm like, no. thank you for doing the work that you do and everyone in your team, because as you mentioned, like when I was diagnosed, it was, you're going to be blind, and there's essentially no hope. It's no hope. And then your life is sort of, when you're growing up, is split into like, all right, well, this is my life now with vision, and then when will it end with vision? So it's sort of like, and that's sort of coming, and there's not really that much hope on the horizon. And then, 10 years on, there's something coming up. It's 5-10 years down the road. It'll be here soon. And you're like, oh, okay, cool. You're sort of hopeful. And then I've heard that for a long, long time. And then, more recently, hearing a little bit more, but really like you're sort of a little bit hopeful, but you think, it's still 5-10 years away. And then, out of the blue, suddenly one of Lauren's team members called up and said, we have this trial. It may be beneficial to you, but it will be beneficial to future generations as well. And would you like to participate? And like, why wouldn't I? So, there's different risks involved, and they go through all of that. And, I'd say to anyone in the room who is ever considering something like this, the best way is just to weigh up the risk and the reward and the benefit for others, and they're really your three factors. And in terms of participating in the trial, it was quite a extensive process to find out whether you could be part of it, whether you met the criteria. And myself, and I can say my brother as well, he has the same condition as me. We're both really, really keen to be part of the trial. Although there's no guarantees, it's something. It was some sort of hope, and it was the first time we've had that. So then you go through that process, and there's a whole lot of tests. I can't even remember how many days it was now. And there's all sorts of vision tests. It looks like something out of Stranger Things or the X-Files that you're doing with these flashing lights everywhere. But and then the mazes. But one thing for your vision is, like, you have to do well. Like as I was saying before, like a blood test is a blood test, and they'll say, this is the results. Whereas when they're testing your vision, you've got a button and you're trying to react quickly, or you're trying to not knock over the boxes in the maze, or whatever it might be. So you build up that sense of pressure on yourself to try and do your best, so you can hopefully be part of it if that's what you want, which is what I wanted. That was quite stressful. But I was part of the study, and I'm really grateful for that. And
No, it's amazing. And look, again, I can't thank you enough. So, one of the really interesting things for us, I think, as researchers too, is this dichotomy between what we measure in clinical trials and in the lab, and how it actually is relevant to real life.
Yeah.
So to give you guys an idea, I think probably most of you have been to an optometrist at some point in your life, and we ask you to read black letters on a white chart, and it's completely removed from real life. You never have that sort of situation when you're walking down the street. So I'm quite interested, Cam, in what parts of the testing have you sort of gone, okay, this makes sense to me, and which parts are you like, this is so bizarre, why am I in Stranger Things?
So the standard vision chart, it's funny. So you sort of, maybe I noticed my vision getting worse, and then in one eye, let's say, the eye that I haven't had done. I think I can say that, can't I? The eye that I haven't had done. And I'll go to there, and I'll say, I'm sure it's getting worse here. I might, but and they'll do all the tests, and then looks the same. But it doesn't always capture the reality. Like sometimes, seeing from a distance, everything looks okay, but then when you're looking up close, it's a bit blurry. Some of the light testing is really hard. You're looking at like a black or like a dot in the middle with your chin on like a big round, and you're sort of there for like it goes for like 15 minutes.
It feels like weeks.
and you're all the red lights and then the blue lights, and you're having to. That does feel quite like it's not your functional vision. However, I do understand the reasons behind it.
Yeah.
On that, they put you in a little, I call it the cupboard, essentially, to like dark adapt beforehand. It's just like a little, oh, let us know if you need anything, and you can't go on your phone or anything. So I've started stretching and doing things like that in there while I'm waiting. There's not much.
Bit of yoga.
Yeah,
I like that.
Yeah.
Oh, fantastic. I think this is something that I'm particularly passionate and interested in. So one of the experiences we had with the bionic eye trials is we had all of these, very elaborate lab tests that we developed. And so we were getting people to look for objects on tables and do things on computer screens. And then it still really gives me goosebumps thinking about it. But one of the ladies came in one day and she said, you know what? I've been going to the same coffee shop every day for years, and I never know where the barista is when I'm ordering my coffee. So I walk into the shop and I just wait till he comes to me. And she said, the bionic eye is not giving me a huge amount of vision, but means when I walk into the coffee shop, I can see where he is and I can walk straight to him and order my coffee. And it's those sort of stories that are actually really hard for us to record as researchers. We've also had reports of things, people say, I can't read your visual acuity chart, but I can see the gap between my wife's teeth when she smiles. And, how do you measure that? So it's an interesting dilemma for us as scientists to measure vision in a way that means that the regulatory bodies will approve the treatments that we're developing, but also capture that, capture the real life side as well. So I think some of the take-homes really from this talk that we're having is, there are so many different types of vision loss and different conditions, and there are so many different treatments coming down the pipeline. And one of the things that Cam and I have talked about in the past is this interesting challenge of making sure that everyone is aware of what's coming down the pipeline. And in inherited retinal diseases in particular, we actually need to know the genetic information. So we need to know what gene someone has before we can actually, recommend them for a treatment. And this is a really interesting challenge because in Australia, we've not done this historically. We have only offered genetic testing to people who are about to have kids, and that's been about the maximum. So part of what we're now doing is really trying to test as many people as we can and get people onto our registry. So our research is around trying to bring in as many people as we can, make sure that we know as much details as we can about them, so they're ready for clinical trials as well. It's really important as well, I think, that, when we are talking about some of these treatments, that we do try and educate both people who have low vision, but also the clinicians about the fact that there is no one size fits all. And we really wish there was. I think, every time we're at a conference, we go, oh, it would be great if there was a one and done sort of solution. But that's where it's very exciting because there's a lot of crossover. And so some of you in the room might be aware that the bionic eye, was a really big thing a few years ago. Now gene therapy is probably a little bit more attractive. But there's actually evidence that we might be able to use some of the bionic eye concepts, so some of the electrical stimulation in combination with gene therapy or with other drugs to actually maximise the outputs as well. And that's, again, another big take-home, I think. There are no failures in research. Even if something doesn't work, we end up using that again in another way as we move forward. So that's, quite exciting. I'm aware we're chatting, I knew this would happen, we're almost out of time. I'm going to throw back to you, Cam. Is there anything else you'd like to share with this amazing audience about, your thoughts on this topic?
Yeah, well, from my experience, if there was anyone in the room who knew someone or they've had a recent diagnosis or they work with people who have inherited retinal disease or any low vision condition, my advice would be for that person just to, if they have the capacity to know the science and try to learn the science as best they can, as whether they're in the field or they're a lay person as well, and just finding out, because I think the more information you know, the better, and then you can make informed decisions yourself about what job you want to do and if treatments come up and everything you do in life. So that's been something that I've always really tried to do, and I think it's worked out okay, but it's not easy. The there's you often think, oh, why me? I sometimes think if I had 20/20 vision, that would be like equivalent of someone else having a superpower, because, but we're all different, and we all have our challenges in life, and this just happens to be mine. So,
Oh, beautiful. That beautifully put, Cam. And I think from my side of things as well, I'm hopeful that you see, how important it is to have this sort of connection, I guess. And we're really, really keen to make sure that all the work that we do is very much driven by people that have lived experience. For example, we actually just did a study a couple of years ago now, but we thought, there's all of these gene therapies coming out and all of these other treatments. No one's actually asked people that have got these conditions what they think. So we did a survey of 1,500 people around the world that had inherited retinal disease and said, look, what do you think? What are the barriers? And interestingly, most people said that they would have the treatments. About 92% said, yep, sign me up today. But only about 24% felt like they were confident about what that actually meant. And so I think that's my other take home as well. And Bruce beautifully put this at the start of the night. We don't want universities to be a silo. We want to be able to share knowledge with everyone. So we would say if you or someone in your family has these sort of conditions, obviously reach out to your clinicians, but reach out to the researchers. We know what's coming, and we can also help with the directions. And hopefully, the combination of the science and also the lived experience really helps to accelerate this field forward and have some cures in the future. Thank you so much for listening. I'm sure that's probably raised a lot of questions for Cam and myself. So we would like to now throw it open to you all, and thank you again for your attention.
That was just absolutely terrific. And also, thank you so much, Cameron, as well, for sharing your story, because it really adds the context to all the work that we actually do. So this is an opportunity for us to be able to have a bit of a chat, bit of a chin wag, and try and get a bit more of an understanding of what's going on. I just want to kick this off because I'm of the age where I remember the bionic man and the bionic woman, where these are rebuilt bodies, and not only that you could see everything, you actually had X-ray vision as well, and you could see on the other side of the world. But the cold hard reality, that's not the case when we start doing this sort of stuff. And I know with the cochlear ear implant, you think you actually can hear everything, but you can only hear a very metallic sound of voice only. You can't hear music. And you can't actually and I'm a musician in my other life, and you can't tell where the sound comes from.
Yeah.
However, what's critically important is how it improves quality of life. Just the fact that you be able to communicate. My wife also has a neurological condition where she uses a wheelchair. What would alter her quality of life was being able to transition from the chair to bed by itself. So I actually wanted to kick it off for you, Cam, as well. What would be like the one thing, because the good thing about it, we don't need to give you X-ray vision. Kind of handy to have that, wouldn't it? Wouldn't mind that. However, what would be one thing for you to all of a sudden, this would be great if I could do that?
Wow. There's a couple things. With the gene therapy, as Lauren referred to before, just halting the condition is, I want to be able to see my little girls grow up, and I want to be able to see them enjoy their lives and just participate and watch them get married one day and those sort of things. So that is important. So just having some vision. We're talking, being able to see at night would also be nice if I had a wish list. But yeah, I think the first thing is really, really important, being able to halt that and go from there.
That's just fantastic. I've been told there's a question up here somewhere, as I'm trying to see as well, because I've got all these lights in my eyes.
Thanks so much, Lauren and Cam. I have learnt so much tonight, and I really appreciate you coming out and sharing with us. I've got a million questions. Sorry, Lauren.
Absolutely.
I'll try and just ask one. I'm curious about, you talked about the brain and the amount of work it does when you're trying to see, and when your vision is affected like Cam's, what is, like, I feel like there's a real level of exhaustion that comes with trying to see when you have parts of your vision that aren't there. Can you talk about that from both of your perspectives?
Yeah, absolutely. So I'm happy to start and then throw to you. Look, this is absolutely something that we hear all the time. And it is this thing of, in a way, you're kind of almost sometimes fighting your brain, right? You're sort of going, is that real, or is that filling in or something? And so, yeah, it can be very tiring. And I think that's something that people don't realise. And again, Cam is by far the expert on this. But yeah, definitely a lot of people that I work with do mention that it's incredibly tiring. And depends on the circumstance as well, right? So a crowded environment, busy public transport, those sort of things can be even more.
I think what you said about circumstance, and also, I'm also very fortunate that during the day out in the open, I can function okay independently. So for me, in that sense, coming home from work at the end of the day, I'm probably just exhausted from work. But what you said there about crowds, sometimes like I have to walk through a crowd, and like when you get to the end of that, it's just like, like I made it out, like sort of thing. So that's that relief that I made it out without bumping into anyone or embarrassing myself or whatever it might be. So that's something that for me, I find challenging and is harder in terms of just out exhaustion. I think because my vision is still okay, I'm not having to struggle with that at the moment, and hopefully with this trial and this treatment, maybe it will stay that way.
Because the psychological load as well it just uses a lot of energy, and I don't know, separately during COVID when everything was on Zoom, and you have the Brady Bunch sitting on there, it was actually well and truly published. To actually do Zoom meetings in that scenario, it has a greater cognitive load, takes more energy. And I'll never forget coming out of COVID when you were sort of allowed to socialise a little bit outside, and my wife had a couple of her mates, and you forgot how you use all your other senses. So someone was talking to me like one-on-one here, but I could hear the conversation over here, and we could see someone in 3D as well, as opposed to 2D. And that's well and truly described especially people with disability overall. It's one of the main reasons why they're tired, the cognitive load, the anxiety and the stress associated with all these things just takes energy. And so it is one of the things for everybody else who's not living with disabilities to actually understand that. It's really important. It's a question here, I think.
Yes. Hello. I don't know if it's super loud. I don't know where to put the... my name is Paris. Thank you so much, Lauren, Cam. This has been a really entertaining and interesting and fascinating talk to listen to and be here for. So thank you. I'm curious, Cam, you mentioned about, encouraging people who might have a newly diagnosed condition or know someone who has a genetic condition and whatnot, and encouraging that kind of research process and finding out about it. I'm curious, Cam, how have you found, I suppose, in finding information, as someone with lived experience, how have you found the process of finding information, say early days? Obviously you were younger when you kind of were diagnosed, but how important was community and kind of peer support or even family support in that journey of finding information and kind of learning about this yourself as well? So the clinical side is supportive, but also the kind of, I guess, community side. Because I know with lived experience, that's something that comes up quite a bit.
Well, I can talk about what not to do because me growing up, being a teen, probably typical teenage boy, don't want to talk about it. And didn't really talk about it. And I don't think that is probably a good thing to do. That sense of community. I often think I would have really benefited from speaking to someone who had the same condition or similar condition, because I had this sense of, you don't really know what it's like type thing. So that would be one thing. Another, it sounds silly, but like I remember in high school just studying like year 10, 11 biology and like understanding and learning about, about chromosomes and genes and stuff. And in my head, I'm like, oh, okay, and making connections. And then, growing up, a love of science and listening to podcasts and things like that and reading. So just that general knowledge of science for me has been beneficial, because when I have these discussions with people like Lauren, or I have that understanding, and I think that and listening to the experts out there is really, really important. Finding a good doctor who can support you, and I think that's important.
I might just add to that as well. One of the communities we work really closely with is with a condition called Usher syndrome. And so with this condition, children are, depending on the subtype, they're born deaf and then they lose their vision later in life, so late primary school. And it's a really interesting thing. We've recently been running some camps for these kids, and we were running some focus groups at a camp that we did last year. And one of the really strong things that came through is for these kids, they don't really know where to identify. They're like, I'm not really in the deaf community, but I'm also not really in the blind community. And they spend their life explaining to people, what's going on. And it was just this beautiful thing that for them, they all got together and they were like, you know exactly what's going on. And they were rock climbing and surfing, and like they didn't have to spend their life explaining. I think that's a really nice thing when you find people that just get it.
We have another question here.
Thanks so much to the two of you for giving such an in-depth talk. I've learned so much today. I was searching up a condition my friend has recently. It's called keratoconus. And she was talking about there not being much treatment available for that. I'm wanting to know if you're aware of what is in the works to treat that condition.
Absolutely. So keratoconus, again, we're really imaginative in our field. So conus means that it's shaped like a cone. So it's when the cornea, which is the front part of the eye, the clear window at the front of the eye, becomes shaped like a cone. And so historically, there wasn't really much we could do. So people start off in glasses. They get to a point where they need contact lenses to fit onto the cone on the front of their eye to give them good vision, and then they'd need a corneal transplant after that. There is actually a pretty new treatment out, which you should look into, called corneal cross-linking, and it's actually a technique which can make the cornea stronger, and so rather than bowing forward, it kind of keeps its strength and its shape. And I'm very happy to give you some names of surgeons if she's interested.
We have a question over here.
Thank you, Lauren and Cam. Amazing presentation, but also amazingly put together. It's like a storytelling. We really loved it. Quick question. All these research, new therapies, gene therapies, everything that's coming up sounds really good. I'm just talking about the accessibility to the common person who couldn't be in a clinical trial. And what do we know about that?
Excellent question, Hannah. So one of the challenges is, I mentioned before that there is one gene therapy that's approved on the market. What I didn't mention is that's $1 million for a treatment. We're very lucky in Australia. So our government subsidises that for people that meet the eligibility criteria. But one of the things that I'm, quite passionate about is there's obviously countries where that doesn't happen. The other thing that we know doesn't happen is that there are people that don't get access to the eye care that they need to be able to access these sorts of treatments. To give you an idea, the gene therapy trials that we're talking about, they're only run in Melbourne and Sydney. So there's 2 centres, and at the moment it's sort of, if you are getting access to those centres and you know the doctors that are involved in the trials, that's the people that are at the moment in our trials. So we're actively trying to change that. We're about to start doing more decentralised trials and having sites around Australia, but it's an issue.
And it comes back to what I was saying. Just if you have the capacity to be aware and up with the science and build the connections, it can help. Obviously, the future generations, but it can help yourself as well.
Absolutely.
And as you sort of feel powerless sometimes. So for me, like anything I can do, you try to do. So
absolutely.
We have a question over here as well.
Thank you. Great dialogue, and we enjoy it very much. This is related to supplements. Do you value supplements like lutein, zeaxanthin, astaxanthin?
Right. We were just talking about making sure you're educated about your condition, and you obviously are, so well done. So these supplements are for a condition called age-related macular degeneration, which is a very common retinal condition. There was a really big study done called the Age-Related Eye Disease Study, which showed that those supplements can help people with some types of AMD. And so my general gist is obviously have a chat to your doctor, because they can tell from what your retina looks like whether it's worth taking the supplements or not. Because there's some people that we say absolutely worth it, some that it's probably not. So
When would you start that?
So again, it's if you do have the subtype where the evidence is that it can make a difference, then we usually get people taking them as soon as possible once we see those changes.
Okay, thank you.
Actually, on supplements, it's very interesting. One of the other inherited retinal disease treatments that I didn't talk about is there's a lot of interest into antioxidants now. And so again, this is a tablet. We've just finished a 5-year trial where people took a tablet every day, and we showed that we could decrease the damage to the retina by 50% over that time. So supplements definitely shouldn't be discounted. I think there's a lot of evidence now that they are making a difference for some diseases.
Do we have anything to fight cataract?
So interestingly, there's a little bit of research, but because the surgery is so effective, it's not as big a field, if that makes sense, because people know if you get a cataract, we'll do a 7-minute surgery and it'll be fixed. So there's a little bit, but not a huge amount.
Thank you.
So with the approved treatment, is that a viral vector one for the retinosa pigmentosa?
Yeah, it is. So it's a drug called Luxturna. And so it's a viral vector with a correct version of the gene in it.
Okay.
One of the challenges is it's for a particular type of inherited retinal disease that affects kids. So kids are born with vision loss, so quite different to what Cam's experienced is. And it's very small numbers. So it's about 2% of people that have retinitis pigmentosa have that particular gene. So while it's incredibly exciting and we're very happy that it's in Australia, it's only ever going to treat tens of patients rather than millions.
And what kind of treatment is the patient here taking? Is that a
Cam, yep.
Yeah. So Cam's in a gene therapy trial as well.
Oh, okay. And that's a totally different type of gene vector? Or?
Yeah, correct. So different gene, different sort of,
Has it delivered?
Well, okay.
Yeah.
I think it's. I'm very happy I got it. I see some results. Yeah, literally. It's.
How do they do it? Like a needle straight in the eye, or?
Well, it's for me. It was a surgery. Yep. They said we can put you to sleep, or you can watch the needle go in your eye. And I said, sleep, please.
Sleep.
I'm with you, bro. Knock me out for a week.
But Lauren can correct me. They basically detach the retina, so that film, that tissue, and they inject the vector virus into the retina. With a needle straight in, and that's how they deliver it. The recovery was, I think I went back to work about 2 weeks later, probably a couple of days early than I should have. But and since then I started noticing some differences after about a month. And it's not like, oh my gosh, all of a sudden I have 20/20 vision, but it's a bit clearer, and that's amazing.
And that improves quality of life. We're almost out of time. This is a question about the future, I suppose. And the way it comes to me, my wife mentioned to me quite a few years ago, my background's asthma, and she said, you keep on looking at a cure for asthma. And I go, yes, darling, I do, because it's such an important condition. And she said, well, I'm the one using a wheelchair. Oh, okay. Sorry, love, but I just don't do genetics, which her comment was, well, I thought you were a real scientist. Ouch. Mic drop, You are a real scientist. You are a geneticist. What's on the horizon, and how quickly can we get this done?
Yeah. Look, I think
now.
Yeah, there are so many incredibly exciting things happening. As always, the answer is unfortunately funding. So we have things at the moment in the lab that we are 99% sure will be really effective, but we don't have the funding to get it into a trial, and that's pretty heartbreaking. One of the developments that we have got at the university is a treatment which can change the function of cells. So if your photoreceptors are dead, maybe we make some of the other cells in the eye react to light as well. So that thankfully has got a little bit of funding recently, and we're pushing forward on that. But it is that thing. If we invested more in medical research, we would have a lot more treatments to show for it.
So on that note, can we just actually serious noise for these two amazingly human beings?
Thank you for listening to the podcast series of Raising the Bar Melbourne, a special health edition. If you want to listen to more Raising the Bar talks, head to rtbevent.com/podcasts.